this field. So I have nothing to disclose. This is a simple case. It's a case of mine, like around 10 months ago. She's a 50-year-old lady, presented with neck pain and left-sided radicular pain, with weakness in the left deltoid biceps and triceps weakness. With normal gait, I tried conservative treatment for 2 months without success. This is here MRI. It's almost similar to your case, Sameh, but maybe more worse. It shows a 3-level disc diseases with the spinal canal stenosis and some change in the cord at C3, 4, 5, and 6 levels. This is the axial MRI. And this is my solution. Since I like to stand alone, I decided to perform a 3-level ACDF without a plate for this case. And this is the 10 months post-op. The patient regained full power, very good result, and she was happy. Back to the history of ACDF. Actually, it's a time-tested procedure. It started since 1955, where it's described by Robinson and Smith, and then followed by Cloward in 1958. So it carries a well-established result during all these years, and rarely nowadays you can find a procedure that lasts for all these long years with very minimum complications and good results. But the key for success of any surgery, including the ACDF, is the meticulous attention to the details. If you choose your patient properly, if you select your case properly, you find a good result. So you have to carefully choose your approach, your patient. If you have, like, for example, a sagittal alignment or kyphosis case, personally, I would go from anterior, but this does not mean that every case of kyphosis can be tackled by anterior approach, by any mean of anterior approach. For example, if you have a case with for example, focal kyphosis, and then you decide to do a total disc replacement, arthroplasty, this is a bad indication. So try to select which case to go on and which approach and which procedure. Extent of the disease is another factor that play very important role in how to choose your approach and your procedure. If I have 1 to 3 and up to 4 levels, I prefer to go for ACDF. If for more levels, I would prefer to go from posterior. The dimension of the canal also play an important role. For example, if you have a congenitally narrow canal, posterior approach is my favorable procedure. Location of the pathology, presence of axial neck pain, all these are factors which play very important roles in decision-making for your approach and your procedures. Personally, I would love to do CT scan for every case of cervical spine where I decide to operate, because it will give me more information about my case, and it will actually guide me through the approach I used and the procedure I used. If you see this case, for example, it seems to be like a single disc in the foramen, and probably many of you and me would like to tackle this case from posterior by only doing discectomy and foraminotomy. But when we send this case if you send this case for a CT scan, you will find that this is a bony. There's a bony element here, and this bone will affect your decision making, and totally will change my plan to go from anterior rather than from posterior. So why ACDF? To me, it's an MIS procedure. You will have only to cut the skin, and then every other dissections will done by muscle, by finger dissection and soft tissue procedure without cutting any other element. There's no blood loss in this procedure. It's a procedure which preserves the stability. It's a procedure which restores the alignment, and you can achieve direct and indirect decompression. And it's a forgiving operation if you compare it, for example, to other procedures like the TDR, when you have to take care of every single detail, including the preparation of the end plates, removing osteophytes, implant position, implant size. But with the ACDF, we have seen many cases with less than ideal dissection and less than ideal cage implantation, but ended with good diffusion and good outcome. And it carries a high fusion rate. Go back to the techniques. You have to check the OR setting, the availability of microscope, the availability of C-arm. Position is very important in this procedure. I personally use a smooth pillow behind the shoulder to get some minor extension of the neck, especially in short neck cases. And I use tapes to fix the forehead to avoid rotation of the head during the operations, and also tapes in the shoulders. But I try to keep the shoulders level for this approach to get a good AP view. But remember that one of the tips and tricks here in the approach that we may see cases in which we try to achieve hyperextension during approach, but afterward we found an exacerbation of the existing spinal cord compression and neurological deficit. So the tips here and the tricks is that you have to test the extension posture before surgery to exactly conclude which case that might become worse if you do hyperextension position during the surgery. You have to check the level, and you have to see the involved level clearly in the C-arm. All this preparation should be done before you enroll into the surgery. I mean, you have to check every single detail in this procedure so as not to run into trouble. You have to see parallel facets and true lateral X-ray and C-arm to avoid rotation. You have to see parallel end plates and level shoulders. If you see this is an X-ray here, in which it's shown that superimposed facets which is not parallel, and this will affect your placement of the cage and your intraoperative problems in the operative procedure. For the side of the approach, I personally, if I have case of foraminal pathology and disc herniation or osteophyte, I personally prefer to use the contralateral approach side, because I feel myself more comfortable to see the pathology on the other side in my eyes. So I can remove the disc. I can do more proper foraminectomy and foraminal checking. But if you are, I mean, in many surgeons, I have seen many surgeons, they don't like to use this kind of approach. The general recommendation is that you can use from C2 to C6 any side approach, whatever you feel that comfortable. And from C6 to T1, there is some favorable papers that favor to the left side, because it will show significant lower rate of injury to the recurrent laryngeal nerve, although another papers show different scenarios. But in the same way, I want to mention that the injury to the recurrent laryngeal nerve is not only an approach related, it's something that related to the excessive retraction done by the retractors, and also by the endotracheal cuff pressures. So many papers postulate that you have to take care of endotracheal cuff pressure and retractors to avoid this complication. Thoracic duct is on the left side. It's a very rare complication, and it's uncommon to happen, especially if you are stick to the anatomical planes of your approach. Let us go with the skin incisions. Usually I prefer to use the midline transverse incision with a 3 centimeter Langer's line, because it's carries more and a good cosmetic effect and appearance. And I usually can access 2 levels with this approach. I have seen many surgeons, they can access 3 or more levels with this approach, but personally, when I have 3 or more levels, I shifted my approach to more vertical or oblique approach. As I mentioned, that the only cut that I did is it's in the skin. Otherwise, every other soft tissue can be dissected carefully without bleeding and without significant cut. And then we can pass into avascular interfacial plane between the carotid sheath and the trachea and esophagus till reaching the prevertebral fascia. I prefer to use the hand retractors. In my early careers, I used self-retaining retractors, especially for corpectomy cases, but I developed some of the complications with this retractor, so I shifted to hand retractors. And the issue of excessive retraction is something that's extensively discussed in publications, and they showed that significant decrease in intraosseous pressure and hypoperfusion rate when using manually controlled retractors rather than the other retractors. So it will affect both the dysphagia and dysphonia occurrence rate. Another one issue that can be happen with the prolonged retractions. This is a case series published in Spine in 2004. It shows that the patient developed a lethal stroke after cervical spine surgery due to prolonged retraction to the normal common carotid artery. This is on the left side of the screen. On the right side is a case of mine where I performed a corpectomy with ACDF, and it's before like 6-7 years ago, and actually the operation lasted more than I remember 4 hours, and I ended up with hemiparesis after the operations. The case developed hemiparesis, but fortunately the patient regained his full power after a few days from the surgery. Localization, again, I used the needle localization when I am sure about that I have multi-levels, or I'm more or less sure about my site, my level. But if I am not sure, I don't use the needle for localization. And this is another paper published that showing that incorrect level needle localization may increase the risk of adjacent level disc degeneration in the normal disc levels. Then when we reach the midline, we have to identify the midline, which is the midpoint between the longus colli insertions. This is more important in arthroplasty than in ACDF, although it's also important, but it's very important in arthroplasty cases. I do careful mobilization of the longus colli muscles with careful dissection to put my blades beneath it. And because there is a reported, although it's rare, very rare, but there is a reported cases of Horner syndrome, which can happen if you manipulate the longus colli muscle, and if you dissect it with monoboral cautery, or if you place the retractors blades above it or up on the longus colli for a long time. Osteophyte resection, it is also something which is very important in arthroplasty, less important in ACDF. What I mean is an anterior osteophyte. Usually I use the rondule or drill to remove these osteophytes. Then I use the sharp knife to cut the annulus, then curate and rondules to pair the endoplates. If I have a case with radiculopathy, and especially if there is some bony elements, I try to do posterior uncus resection. What I mean uncus resection is not total uncus resection. I usually remove only 1/3 of the uncus if I have a bony element. And in cases where there's only myelopathy, most of the work will be central, and I remove the osteophytes with the rondures carefully from the central part of the field. Regarding the PLR resection or preservation, again, this is a matter of debates, but personally, I remove in all cases, I remove the posterior longitudinal ligaments, and I have reviewed many papers, and they show that it improved the outcomes, and it shows no significant difference in complication rate. Stay in the midline in every case to avoid arterial injury, and the key of success in this surgery is to take meticulous attention to the nearby structures, including the vertebral artery and the carotid artery. So maintain midline orientation and make marking before the section of the longus colli, and don't pass beyond the ancovertebral joint orientation. With the use of microscope and the field magnification, this complication is very rare. And it's have been known that there is a safe zone of average 3 millimeters to the vertebral arteries when you are limited uresection to the ancovertebral joint line. Then end plate preparation and implant placement. This is very important and vital steps in both in ICDF and in arthroplasty. But it's more meticulous. Should be meticulous in arthroplasty. While in the ICDF, actually, what I do, I remove the cartilage. I try to get a punctate end plates. Then I can use the anatomical cage, lordotic anatomical cage, as wide as possible to get more surface for fusion. While in arthroplasty, you have to take this consideration very careful to flatten the surface to get a very good surface for the arthroplasty insertion. This is an example of cage inserted in cervical spine. A few points about some other injuries that can happen with this approach, including esophageal injury, which is reported incidence is very low again, but it can happen intraoperatively, or it can be discovered intraoperatively, early postoperatively, and in delayed postoperative period. But the key for
sorry, Dr. Muzahim, you have 2 minutes only left.
Yes. Okay. So the key for this case is the early diagnosis and early management. Dural tears overall incidence is very rare, and the main risk factors is when you have ossification of PLL and in revision surgeries. Whether to use a plate or not, it's another debatable issues in ICDF. But I can conclude that plating will reduce the rate of painful subsidence and enhance the rate of fusion, but it will prolong the time of surgery with highest cost and possible dysphagia, although it's a controversial issues. Finally, ICDF versus TDR, this is a very hot topic to discuss, but I can just summarize that the original thinking of, or the original excuse of using the TDR is that the possibility of adjacent segment degeneration that's shown in the literatures more with the ICDF than arthroplasty, but in fact that it's more or less just a radiological finding, and these findings have no clinical symptoms and has not been established to be correlated with the clinical outcomes. So I can say that fusion is the same. Realignment is better with the ICDF. Stability is better with ICDF. MRI compatibility is better with ICDF. So why I use cervical disc replacement if the rate of spontaneous fusion is unknown, if the accelerated adjacent segment degeneration is not proven, if its role in mono or multi-segment cases is not proven, and if its effect of altered kinematic is unknown. So my take-home message is that ICDF is still the gold standard procedure in cases where the pathology is more anterior and more facet joint degeneration, and it is an alignment preserving operation. It is an MIS procedure, but better not to use it for more than 3 or 4 levels. And in cases if you have a soft disc prolapse in young patient with good bone quality and disc height and minimal facet degeneration, arthroplasty may be better than ICDF. Thank you so much.
Thank you, Muzahim, such an excellent presentation, and definitely raises the question of ICDF versus TDR. And I guess Oscar will be the better person to talk about this. But before we move to the motion preserving surgeries, we'll continue with the fusion surgeries, and I'd like to ask Naif to go ahead and share his screen. He will be talking to us today about the posterior cervical laminectomy and fusion, claiming it to be the best surgical option. Naif, you can share your screen.
Can you guys see it? Hello.
Yeah, we
Good
do.
afternoon. Yes. Do you hear me?
Yeah.
Yes. Thank
okay.
you. Thank you for the beautiful illustration and paper presentation. I would like to ask the indication of applying the blade while doing fusion in multiple level disc surgery. Now you presented 3 level without blade. If I am going to have 4 level cages, anatomical cages, can I use a blade or no blade even if it is 4 level fusion? Because you used to do the blade for 3 level fusion at a former time, and you stopped doing that. We shifted to the standalone cage and make the cage more anatomically suitable to the disc space after preparation, and we just forget the blade, and this, in my view, is needed for more than 3 level at least for the stability. I would like to hear your comment, please. Thank you. Ahmed Mazat from Cairo.
Dr. Mohammed Maziad, if you don't mind, for the sake of the time management, we'll actually be continuing with the presentations with a promise to start with your question. Once we start the question and answer, immediately after we are done with the 4 presentations. So
okay, thank you. Thank you.
Starting with your question once we are ready for the questions and answers. Thank you.
Do you hear me, guys?
Yeah, go ahead.
All right. So I can't say that the posterior cervical spine is the best because it has its own indications, but actually it's really a good option in some cases. So I have nothing to disclose. Looking into the literature, it's really hard to find certain indications specifically to go with the posterior. It's always in the discretion of the surgeon whether to go anterior or posterior. However, there are like some papers, I summarize them here. Some of them were talking about the revision. If you're going to revise the case of an anterior cervical fusion, then your other options to go posterior. Also, if it's part of the staging plan of a patient to go anterior, posterior, or vice versa. Some other clear indications are the post-laminectomy kyphosis. If the patient has congenital cervical stenosis, as Dr. Mazahim alluded to, if you have deformity correction, and if you have a failed anterior approach in terms of pseudoarthrosis as well as trauma and tumors and infection. To take home message, the most common indications are kyphosis if it's flexible and less than 10 degrees. And as Dr. Muzahim alluded to, if you have more than 3 levels pathology, then this is an option for you. You always go where the pathology is and clear.
Sorry, Naif. Can you preview your slide because we just see the first slide till now?
Sorry.
Can you preview full preview your slides because we are just see the first slide, not it. Yeah.
Oh, sorry.
It's not in the preview mode. Yeah.
Can you see it now?
Yeah, just make it bigger in a slide preview mode.
Mm-hmm.
I don't know how to do that, but
so you are using Mac or
Mac.
Windows?
Mac.
Yeah, I think you have to change to the preview mode in the setting of Zoom, or you can go. Yeah, it's okay now. You can go like that to save time.
Interesting. Do you see it now better or no?
Well, I think it's just better if you move one slide at a time, and then instead of going to the preview mode.
Yeah, it's okay now. Let's go on to see.
Sorry, I don't know what's going on here, but I'll just keep going.
Go ahead.
Can you see now?
We do see the indications slide.
Okay. So pseudoarthrosis is another option, and that's in case of failure of anterior fusion, considering that the anterior plate and the graft has not changed or subside. The major considerations have been evolved the recent literature talking about considering alignment measurements, whether it's regional or global or focal. as you're always measuring the lumbar lordosis and pelvic incidence, this is the same thing you have to apply actually here too. Careful imaging review, you need to achieve the cervical lordosis of what the patient is expected to have. Looking into... Yeah.
Sorry, but your slides are not moving. So your slides are not moving. So you'll have to cancel the preview mode, and you'll have to move with the slides without the preview mode. Yes, exactly the same that you're doing.
Yeah, it's okay now. Consolidation.
Sorry, my apology for this.
That's okay.
I don't know. So you need to consider your alignments, global, regional, focal, review imaging properly, as well as you need to achieve. Hello?
Go ahead.
You always go where the pathology is, and you always need to figure out why the failure happened, if it's because of the patient or the surgeon or the implant. As Dr. Muzahim alluded to, it depends on the cervical alignment, the number of stenotic levels, the location of the compression, and if you have like an anterior issues, you cannot go anterior, then you salvage procedures to go posterior. This is a really good paper reviewing the importance of cervical radiographic alignment to decide the relation between the pelvic incidence and the lumbar lordosis, but also to consider the cervical lordosis as an important thing. I'm not going to spend a lot of time talking about this paper, but just to give you the hints of that paper and the bottom line, there is always in this paper some significant statistical and clinical correlation between C2 and C7 lordosis SVA, as well as to the T1 slope, which is very important measure you have to go to measure when doing the cervical spine, because that will dictate some element of the alignment. Looking into this paper, which is the same one I talked about, if the patient has a kyphosis, you can see how much stretch on the cord. If it's like neutral, you have some relaxation, but if it's like lordotic, the cord relaxes and it can shift posteriorly. So it shows you, if you do a posterior decompression here, it's not sufficient to shift or drift the cord posteriorly. This is a patient of mine I have seen, not mine, like I've seen during my fellowship. If you look into this patient, he's 47-year-old, professor at the university, left-handed, has radiculopathy 2 levels. Looking at the extension and flexion images, it seems like reasonable, but he has some focal kyphosis at 5 and 7. But a very significant thing that I learned in this case from Dr. Courier, my mentor at Mayo Clinic, it seems like neutral, like alignment here. But if you measure the T1 slope, it tells you you don't have to go crazy and correct the lordosis in this patient. This patient has a neutral alignment. You cannot correct him into lordosis because he's going to compensate above that. So the take-home message from this slide is, if you have a T1 slope that is like very slow, very low or like flat, that means you need to obtain a full series of scoliosis, because you need to see why this T1 slope is flat. Because most likely the other curves below it are decreased too. So you don't have to go crazy and correct this one, because the patient will compensate above it. As Dr. Muzahim mentioned, looking into the meticulous part of the images, and you can see there's some osteophyte here. But also something I learned too is what's called the foraminal views. I don't know if anyone knows this, but it's something new for me. It's something you can talk to the radiology to obtain for you. It's not like only sagittal and coronal and axial cuts, but they can obtain for you like coronal, foraminal view, where you can see each foramen like clearly if there is an osteophyte or if it's small on each side. But also you can always into the coronal to see your the slide of the uncus on each level and where the pedicles are. This patient that we've done, if you look into his images prior to the surgery, you can see flat T1, but also shows you after doing these standing views that he's hypo in each one of these curves. So there's some harmony in the sagittal alignment. If you disrupt that by going lordotic at the cervical level, that will get him kyphotic above the fusion level, and will make his life difficult. So this is something I learned. It's not always common, but if you have T1 flat, you need to get some images showing the other alignment or sagittal balance. So this patient has 2 levels, as you can see here, C3 and 4, and also 5 and 6, which both have been injected and shows the symptoms relief. And we looking at this thing, at this X-ray from the the MRI, the line, if it's touching the vertebral body, that means probably going posterior is not the best option. And since I'm talking about posterior, you may think I'm going to talk about posterior approach, but actually in this case, we went anterior. So we did 2 plates with the grafts anteriorly. If you look at the images, preoperatively and postoperatively, we haven't corrected that much. It's like his base, we haven't corrected too much lordosis, and his sagittal balance remained the same. Sorry, this slide might be too much, but I think it shows a lot of things here. The cervical sagittal alignment is related to the thoracolumbar pelvic alignment, so you cannot measure one and leave the other. You need to develop the practice of measuring the cervical as you are measuring the lumbar lordosis. If you have a flat radiographical T1, then you need to have 3-foot scoliosis X-rays. And all of the C2 and C7 SVA are correlated to the regional disability and the general health scores to myelopathy. So going anterior versus posterior, this is an AO study, multi-center study done by Failing from Canada, talking about whether to go anterior or posterior. The bottom line of this paper, they show there is not much of difference if you go anterior and posterior, if you approach your patients properly. So they have significant differences between all of these patients in terms of gender and age, if you go anterior and posterior. But it also depends on the practice of your decision-making process between you and the patient, because in other paper they developed also by Failing, so like North American, European, and South like Latino countries, usually they go and prefer anterior more than posterior. But actually, if you go to Asia, that's in that paper, they say they like to prefer posterior more than the anterior. So each one of them has an element of decision-making process between the surgeon and the patient and the other key players. But after controlling all of the factors like the age and gender, after being adjusted, there is no much of difference between anterior and posterior. They're like all not statistically significant. So it shows you, even if you have some statistical significance in not adjusting the all of these factors, but after adjusting the age and gender and smoker, we found there's no difference in all of these outcome scores. They found, it's not me actually. So they said we demonstrated for the first time the patient and the disease factors are controlled. There's the anterior and posterior surgical techniques have equivalent efficacy in the treatment of CSM. So if the pathology anterior, you go anterior. If the pathology like multiple levels, you go posterior. But also you need to look into, I would like to just to draw everybody's attention, especially the resident and medical student, is you need to focus on the alignment. That's your way to go. And that's something you need to address, and then that will make your life easier if you go to other options. So this paper was talking about the cervical spondylotic myelopathy. It's a little bit older, like in the 90s, but the comparison between the anterior and posterior approach is not that accurate to some extent, in my opinion. So, but something I would like to address in this talk, if you take this message out of my talk, I'll be happy. The pseudoarthrosis, your working horse is posterior. In the setting of having anterior failed approach, and after making the alignment is reasonable, as well as the plate and the graft has not subsided, then your way to go approach is a posterior over anterior, because you'd like to avoid the scar tissue if you go anterior, difficult planes, recurrent laryngeal nerve and esophagus injuries, and also going posterior will give you a more fresh fusion bed with posterior approach. It's contraindicated to go posterior when the anterior approach has some element in the migration of the graft as well as kyphosis. This is a study by Jeff Wang, was talking about a retrospective study for patients who failed anterior approach and then they went for posterior approach. I would like to skip all of that to give you the key element of this study. Something you need to know about the definition of pseudoarthrosis, which is something you need, comes into the exams as well as knowing this, is you need, the criteria are reducing the gap between the graft and the vertebral body at the site of the previous bone graft. There is lack of bridging osseous trabeculae, and that's the key word, bridging osseous, and then more than 2 millimeter motion between flex and x-rays in the lateral view. So the bottom line of this paper, there is no difference actually between taking the graft between local areas or iliac crest, but they said if you're doing a posterior fusion as a salvage procedure after a failed anterior, you probably have about 100% fusion rate, which has been replicated in prior studies before this paper. This is a paper talking about neurological complication of cervical spine, namely the C5 palsy. And I believe this is one of the best papers I've read about cervical spine, talking about the mechanism why C5 is the most common reason. And among all of these options, if you look into this image, these anterior fluids anteriorly to the cord is not that much. You can see there's no flow. There is a good flow here, but there is interrupting one, and this is good here. And if you look into this one, the CSF is having a good flow here, but the cord drifted posteriorly and the nerves still attached anteriorly. And that's a mechanism proposed to be a reason for the C5 palsy, among others, like the short nerve, the acute angle of that palsy. So take home message, the approach depends on the alignment and the levels of the stenotic. And if you have a congenital cervical spine, location of decompression and other limitations. C5 palsy has a higher rate of complication compared to the anterior and to the laminoplasty. So if you haven't examined the question, says what is the most common approach that may lead to C5 palsy? It's actually posterior, but it's not that much a difference, but it is posterior. And that's it. Thank you very much.
Thank you, Naif, for great talk. As you mentioned, the posterior instrumentation has special indications. We will continue with third talk, and we'll take the question at the end of the webinar. Third talk will be a motion preserving surgery, anterior approach, TDR, by Professor Oscar Alves from Portugal. Welcome, Oscar, and let's see how can you defend your approach against Muzahim.
Thank you, Kaswan, for having me here on this wonderful webinar. As you said, I'm the only neurosurgeon, so I try to do my best.
You have most of the attendance neurosurgeon.
Oh, really? Very good.
Yeah, they can help you.
Can we...
Naif, can you stop sharing your screen, please?
Yes, please.
Okay, go ahead, Oscar.
Okay, so... Can you see the...
Yes.
Right, so the topic here is about cervical degenerative disc disease, and I will explain to you the reasons why I think arthroplasty, in my hands at least, it's my best option. I have no disclosures for this presentation, and actually I would like to draw your attention to this paper. It's a survey among prominent AO Spine International members, and they all consider that there is a cost noise in choosing cervical arthroplasty and plays a big role on whether or not to offer it to the patients. And actually, we have quite good papers showing that cervical arthroplasty, even at 2 levels, it's highly cost-effective compared with ACDF. And if you pull out data from large national insurance database, which is really the real world data, there is no really big big bias. You can see that TDR was 12% cheaper than ACDF, and there was significantly lower cumulative incidence of reoperations with TDR compared with ACDF. So I think cost cannot be a problem, and in the future more studies will come to clarify this. And you see here on this study, very nice study here with different devices, 1 and 2 level. You always see that TDR was not inferior. In most of the cases was superior to ACDF using different study designs, but all of them were RCTs. And it's clearly that all across different implants, you have very good results. Cervical TDR is probably most scrutinized entity in spine surgery. A lot of multiple FDA trials have been done in the US. And as I shown before, there is very consistent results among different devices. And I think the devices we are using now, so-called third generation viscoelastic compressive, they will show better results. Remember that all these RCTs are done with previous devices. These new ones, they are compressible, they offer greater resistance to angular motion. So there is no doubt in my mind that for a single or 2 level, even supported by the literature, or 2 level disease, either radiculopathy, soft or hard disc, or even myelopathy related to the disc level, that arthroplasty is a standard of care with unprecedented evidence base being showing with long-term follow-up. Some of the studies having 7 to 10 years follow-up to support the safety and efficacy of this choice. ACDF, what are the facts that our friend didn't show us before? It increases adjacent segment range of motion. A lot of clinical and lab studies show about that. They change the center of rotation, then increase the adjacent level intradiscal pressure. So fusion originates, of course, motion loss and stiffness. So the closest thing you can do to an intact segment is definitely arthroplasty. There is a fusion-induced increase in motion, which is linked with increase in intradiscal pressure, and altogether this can accelerate adjacent disc disease. So for me, ACDF, it's clearly a non-physiological surgery. And just want you to think a little bit out of the box and looking at, for example, this very nice work from Pat Worden, showing that as far as your SVA increases, which is something common with age, there is an increase in this ratio of intradiscal pressure in the adjacent level discs, as you see here. So by doing fusions, you are putting a lot of pressure on adjacent levels, and this increases with an increase of SVA, which is quite common with aging. You see also here with aging, you tend to have this increase in SVA, and there are compensatory movements, which are hyperextension at C0, C1, C2, and a compensatory flexion at C2, C7. And if you're doing a fusion, you will abolish this compensatory mechanisms. And that's something you have to think very carefully, because we are doing now fusions in very young patients with a high expectancy, life expectancy, and you are really noising this compensatory mechanism by doing a fusion. Arthroplasty, many biomechanical and in vitro studies show that arthroplasty minimizes a lot of these negative kinematic effects. And it's very important to look at surrogate endpoints for outcome. You need really a lot of patients to show a clear superiority of TDR against ACDF. If you look at a single level, you need thousands of patients to increase the power analysis of your study. So I think you have to look at the surrogate endpoints for outcome, like the range of motion, the quality of motion. And this is what we did in a small study from one of my PhD students, looking at 31 patients with different environments of disc prosthesis, enrolling 31 patients with 46 implants, follow-up of 24 months. We look at the mobility, the radiological outcomes in terms of center of rotation and ROM. And it was interesting to see that arthroplasty could reproduce the range of motion of different spine levels. And they mimic, in a way, the percentage of motion that each level has in a normal spine. And this stability we were able to show it at 24 months, but other studies have shown also the stability of sagittal range of motion over time. There was, of course, as expected, an increased index level and global range of motion with really minor changes in the adjacent levels. And this is a pool of all our patients, and it's very interesting to see that the center of rotation at the operated level, it tends to locate a little bit superior and posterior at 6 months, but it normalizes by 1 year. So that's really after 1 year that you can look at the clinical data and the VAS and NID and other studies and other indexes to show a good result. What about sagittal balance? It's really important. There is a correlation between NDI and cervical lordosis. We also looked at some of our patients, 35 patients. These were the levels that were implanted, and minimal changes on the sagittal balance and the positive effect on the index level angle. And the increase in global lordosis in our cases derives from increase in index level lordosis and not major changes in adjacent levels. This has been shown also with another device by Cédric Barré, showing a good local and global alignment with TDR at 24 months. Here, a meta-analysis showing that comparing ACDF with TDR, it favors slightly TDR in global C2, C7 alignment. At 1 to 2 years post-op, moderate to high evidence that adjacent segments become more lordotic after ADR than ACDF. So, no doubt, it restores quality of motion as a beneficial effect on sagittal alignment. This is a mainstream case that you see here, good indication, minimal spondylosis, a mainstream case. You know, I had this case with idiopathic hyperostosis as a young patient with this herniation and big dysphagia causing by the anterior osteophytes. And we did a 2-level TDR. And you see here with a long-term follow-up, very good prostheses are mobile, good alignment, and you don't see the osteophytes anymore, with a good location of the center of rotation for this case. We had also, you know, TDR is known to allow the index level to regain motion, but would the prosthesis itself limited motion in some way? So we had this case of a young chap with a cervical trauma, with a deep paralysis, grade 3, 1 disc level herniation. The X-ray excluded major instability, and on the MRI, no posterior band lesion. This was the view on flexion extension. And we inserted disc prosthesis in a trauma case, very selected trauma case. And you see that the range of motion decreased from 17 degrees to 9 degrees. So the prosthesis itself was able to preserve mobility, but also to limit the excess of mobility. And this is quite an interesting fact. With 4 years follow-up, we can see that with a very good location of the center of rotation, either at the operated level and adjacent levels. A good option also is when ACDF fails, as in this case here, a patient that I operated in 2010, and we inserted TDR with very good results. So 1 to 2 level, it's a good indication. It's my gold standard indication. Then we started to think, why not to expand indications for TDR? And it's commonly accepted that kyphotic index level is a contraindication, and a collapsed disc with more than 50% loss of disc height and angular motion less than 2 to 3 degrees can be a contraindication. So we did a retrospective study looking at our kyphotic patients at the index level. We had 23 patients, 25 kyphotic levels. These were the kyphotic levels that we operated. And there was a significant increase in segmental lordosis in all the kyphotic levels that we operated by inserting, with no significant increase in global angle, and a little trend towards reduction of SVA. I show you here a case, 30 years old female with the neck and left arm pain, bilateral paresthesia to disc disease, and with this important segmental kyphosis that was not only due to pain, it was long lasting, and you see the result that you could from minus 13.2 to plus 5.3 degrees. So increases certainly segmental lordosis in selected cases might have a good side beneficial effect on SVA. So what about the collapsed disc? Collapsed disc usually represent an advanced form of disc disease, and you always find them on a multi-level disc disease context. Here, a case that it's not different from the one our moderator showed us, and that these are cases that I see more and more in my practice. Young adults, 49 years old, high-ranking public administration official with multiradicular pain, jaw of 14, with multi-level disc disease. And this was the solution that we found for her, and she's very happy, and you know, that's a good clinical and radiological result. Look at that, she had some of the discs already quite collapsed, and see what we gain with the increased disc height in this case. So we did a preliminary study with 7 patients. We have now a paper that is sent for publication with over than 50 reduced disc height cases. And the trend is the same. There is a significant increase in collapsed disc height with ADR. Very interesting, more collapsed discs show the higher increase in disc height, as you see here. There was also an increase in range of motion in the collapsed discs that we operated. And interestingly, the more collapsed discs show the higher increase in the range of motion. So it can be quite a useful surgery in selective cases. This has been shown by Pat Worden in 2016. That's the only study I know about this topic. That really, the results are really the same. So collapsed discs can be distracted 2 times more than pre-op disc height. And they are, of course, amenable to TDR using compressible disc prosthesis. Of course, severe spondylosis with bridging osteophytes, significant facet-joint arthrosis, osteoporosis, instability, global kyphosis remain still a contraindication for TDR. This is, you know, how we see after we do one of those collapsed discs. I don't use Casper retractors, but you can see here how we assess mobility and if it is suitable or not to insert a TDR. You can read this paper that we published in April 2020 on Journal of Spine Surgery about our experience with multi-level arthroplasty. And very briefly, I'm going to go through this if I have still time. As I said, since the beginning of our massive experience with arthroplasty since 2004, we were always very interested in multi-level patients, because if you do ACDF1 level, you don't lose much motion, you don't impact a lot on the quality of life of patients. But when you face multi-level disc disease, especially in young patients with a high life expectancy, multi-level fusion, it's a significant impact in functional outcome in years to come. Multi-level fusion only amplifies the increase in stiffness and range of motion of adjacent levels. You know, a lot of studies showing that the more you do, the more hypermobility you get in adjacent levels. Also, there are adverse effects of multi-level fusion, like adjacent segment disease, hardware failure, pseudoarthrosis, subsidence, which correlates with the number of levels that you treat. You know, cinematics, if you do multi-level TDRs, they are the same as if you do a single level. 2 papers showing with 2-level TDR a good improvement of NDI, patient satisfaction. higher rate of surgery with ACDF, and all the good outcomes. Another study that confirms that by doing more than one level, you don't lose the benefits of TDR. You know, some cases here, again, with this kind of patients that you see today, really young patients with disc disease, sometimes a little bit of narrow canal, and I think it's a problem to offer fusion to these patients in a regular basis. So you can do, like here, 4-level discectomy, and with a long-term follow-up, this is going, and this is good results. Of course, I'm not a fanatic or fundamentalist of TDR, and I acknowledge a lot of contraindications, which I mentioned already, and some are listed here. So my conclusions is that clinical outcomes are similar or even superior to fusion, and many studies showing this, associated less adjacent segment disease with lower reop rates and cost-effective treatment. You know, I think there is a lot of misconception in the segment, adjacent segment disease. What really counts at the end of the day is the need for reoperation or not of those levels. Of course, I acknowledge that can be some bias on that issue. But as I say, I think it's for the future the gold standard for pathology at the disc level. Even if you have OPLLs, only at the disc level you can offer TDR. I think we should proceed on a better device design. You know, ideally it should be custom made, or at level adapt to the level you are operating, because not all the levels in the cervical spine in the normal the asymptomatic patient adult has the same center of rotation. So we need to work on that. There is still a place for improvement. Thank you.
Thank you very much, Oscar. A very controversial presentation. Pretty sure you'll have loads of questions by the end of the webinar. Last but not least, we'll be moving with Don Moore from the University of Missouri. Don will be talking about laminoplasty as the best option for cervical degenerative disc disease.
Thank you. Can you guys hear me all right?
Yep, you can share your screen.
Right. We'll do that in a second. Let me see. That's the one. Can you see the screen?
Yes, we do.
Okay. Well, I want to thank Sam for inviting me to this wonderful webinar. I feel like I've already lost the debate, so I'm just going to try to keep you entertained for the next 15 minutes. If I were that patient, I would have any one of those 3 procedures done on me anytime. So let's talk about it. What else I can do to sort of stir more controversy. So I have no disclosure. I'm always looking for disclosure. But I just want to kind of bring up this topic by talking about this one particular patient I took care of. 41-year-old gentleman, mechanical engineer, very intelligent, was told that he should have surgery immediately, otherwise he'll be paralyzed. Examination demonstrated basically no motion of his cervical spine. He has some weakness, no Hoffman's, no Babinski, no clonus. And here are some of these other studies to look at. So let's just talk about what everybody else talked about earlier. It's like, what are the indications for surgical approach for DCM, meaning degenerative cervical myelopathy? And I think that we'd all agree the location of the problem is definitely important in how we discuss or how we approach it. Is it ventral or dorsal, and how many levels are there? Sagittal alignment, was mentioned by multiple speakers, is extremely important. We all know that the multiple laminectomy alone can cause up to 47% iatrogenic kyphosis, which can be problematic. How about extensive disease? Is it 1 level, 2 level, 3 levels or more? What about in terms of symptomatic condition? Is it radiculopathic patient, myelopathic patient, or both myeloradicular patients? And unlike in Dubai where Sam practices, some of our patients are relatively heavy. I know that he doesn't have any heavy patients in Dubai, but we deal with relatively large size body habitus patients. So approach itself can be quite challenging if someone has a BMI of 50 or more. And lastly, I think the surgeon familiarity and experience is important. And it's what you know and what you can do with the best with your hands. Sometimes better than trying to do what you think is the right thing. But before I go any further, I want to kind of talk about one divergent point. That degenerative cervical myelopathy not is all the same because, the OPLL, which is probably one of the worst cervical stenosis conditions we deal with from time to time, is definitely a different beast. And how different is it? Well, it's like the difference between Dr. Bruce Banner versus the Hulk. So my point is, if you can tame the beast, the Hulk, with a procedure that relatively works pretty well, maybe take care of Dr. Bruce Banner's anger is not so bad. So just indulge me for the next 10 minutes and we'll see how we can do this. Okay. I think today's topic is very interesting, and I know it's been talked about in multiple different seminars and whatnot, but to me, it's like talking about what's the best car to drive. All right, we all know that we can get there from point A to point B pretty well. So let's talk about anterior decompression and fusion, or even arthroplasty with other procedures. So anterior procedure is like driving a nice fancy car. Now you can get there really fast in style. So what about this paper in 2017 that talked about discectomy fusion versus laminoplasty in degenerative cervical myelopathy patients? Definitely you have higher cervical improvement in terms of neurologic improvement with the ADF in patients with SVA compromise. However, if you can see down here, if you don't have any SVA problem, this results the same. Therefore, the conclusion was if you have preoperative sagittal imbalance issues, you should not be doing laminoplasty. I think we all agree with that. What about another paper that talks about how inadequate decompression of anterior cervical procedure compared to posterior decompression and fusion? This study looked at 50 patients who actually progressed after their initial operation. All of them were done who had progression was from anterior procedure, and they felt that the conclusion was difficulty in completely removing the PLL. And I think that some of us, well, most of us agree, it's not always easy to take down a PLL in a real difficult case. So unfortunately, this has a limitation because of retrospective study. Third paper was a meta-analysis of 6 studies that talked about 123 corpectomy patients versus the posterior decompression, either laminoplasty or laminectomy. Now we're switching gears a little bit. I want to focus on the fact that we're talking about OPLL, which is the Hulk, the beast, the bad person, the biggest animal that you want to take care of. So obviously, we would all agree that corpectomy is a direct decompression, and you would expect to have a higher postoperative JOA score. But we need to emphasize the fact that how do you get there? Well, you get there with a lot more complications that is significant. And people may say, well, this is the right thing to do, but I would say, listen, if you can't avoid a complication, unless you're a guy like this who can have a laser focus circulars, it's kind of a tough thing to treat. So how about other patients, other study with OPLL that's greater than 50% canal compromise? Once again, no difference between cervical decompression anteriorly versus posterior decompression. Now again, the corpectomy patients did maintain a better kyphotic alignment, higher recovery, but it did have increased OR time along with the approach related complication. Again, this is a repetitive theme. OPLL, dural tear. Posterior decompression fusion patient, you expect to have a higher blood loss. What about in terms of anterior corpectomy versus just laminoplasty for OPLL? In this particular paper, it talked about recovery rate for corpectomy patients were higher if you had a lesion occupying more than 60% of the canal with kyphotic alignment. But again, they emphasize complications, ECSF leak, implant failure, reoperation, and their conclusion was if you have less than 60% canal occupying condition with adequate low doses, laminoplasty is probably the way to go. So let's talk about laminectomy and fusion, switching gears. So to me, I think most of us are very comfortable with the posterior approach. And I would say this is like driving a car like this, which is like a Land Cruiser that can take you anywhere. So most of us are very comfortable from laminectomy. So how does that compare with laminoplasty? Here's a key article from Neurosurgery Focus from the guys I used to work with. They basically said there's no incidence of difference between excellent to good versus fair to poor, between decompression and fusion versus laminoplasty versus laminectomy in these patients. However, the recovery rate was higher with decompression with fusion. JOS score was a little bit higher, and incidence of OPL progression was much less. So ultimately, they're speaking, they recommended that anytime you deal with the cervical myelopathy with OPLL, you should be thinking about a fusion operation, particularly to decrease the lower incidence of OPLL progression, which is mentioned right here. But they do also admit that higher complication rate, particularly dural tear, up to 23%. And I think the common theme with any type of anterior procedure is really the dural tear. So one of the studies that they mentioned talked about laminoplasty here versus laminectomy and fusion, a small study. However, they looked at an interesting finding, the CT scan follow-up of non-ossified segment of the OPLL. What happens to it when you do laminoplasty versus laminectomy? Well, as you can imagine, with laminoplasty, only 17% of the patient actually ossified this OPLL that was soft, but the majority of the laminectomy and fusion patient actually fused their non-ossified OPLL segment. But I kind of wonder that how are they able to really accurately measure 0.1 versus 0.6 millimeter difference in somebody? Because I don't think my visual acuity is that great to really mention that. But in any event, I would agree that suppressing any type of motion would be likely to decrease the progression of the OPLL. So what about cervical laminoplasty? Well, why do I like this so much? Well, just like the other two cars we talked about, what is one procedure you can kind of do it that's kind of cool, and then not many people do it, and you can really do it well, and it can help the people with perhaps less complication rate. To me, it's like driving a Porsche Cayenne Turbo SE hybrid that can do everything. You can go as fast as a regular 911, go everywhere you want as Land Cruiser, and come in style and be able to tow about 10,000 pounds of trailer. And I think that's what he needs, what Sam drives to go to the bank every day when he makes all that deposit. All right, so why do I like this laminoplasty? Well, I want to emphasize in properly selected patients, it's equally effective depending on what the patient's diagnosis is. To me, it's less invasive. Yes, I know it's not like an ACDF or arthroplasty. You are cutting muscle. There is more blood loss in anterior procedure, but to me, not having to really retract for a long time and make the surgery quicker is better in my hands. Just like the arthroplasty patients, which I really like doing as well, we maintain motion. And I think this is important for younger people. Morbidity, we talked about, is much less expensive. Some of my colleagues actually use Synthes maxillofacial plates rather than using a prefabricated laminoplasty plates, which are really, really cheap. But one drawback with this is I think there's a definite learning curve. First, several of my cases, I got into some complications, including a lot of epidural blood loss, breaking the hinge on the opposite side. We try to salvage that. And one of the first patients I actually encountered C5 palsy, which is quite sobering. But the other options that are available for the laminoplasty is the fact that you can salvage this if it doesn't work out. You can also do anti-decompression. If someone has multi-level cervical stenosis myelopathy, ends up developing a unilateral radicular pain afterwards, you can do a single level ACDF or arthroplasty or whatever you choose and to decompress that level. You can also do a posterior foraminotomy as well. And you can also convert into fusion at the time if you feel like it's necessary. And some of our plates that we use allow that to happen. So what's the ultimate recommendation for gem cervical myelopathy? Well, I think it depends on what you're dealing with. I think we all need to have a different tool in our toolbox to take care of our patients in an effective manner. Not one tool works the best. And I think all these speakers who spoke earlier are right on the money as to what we can provide our patients for care. But don't take my word for it. Here's the recommendation World of Neurosurgery article 2016. They kind of summarize how do we deal with cervical spinal myelopathy patients. So less than 3 levels, ACDF or arthroplasty. I totally agree. In the United States, we can't do arthroplasty more than 2 levels. So I would love to be able to do 3 levels like Dr. Elvis does in Portugal. Lordosis maintain, laminoplasty, neutral spine, less than 3, anterior with instrumentation. Greater than 3 levels of instability, you got to fuse. Young patients, stability, you don't have to fuse, laminoplasty is great. Older patients with ankylosis, I think we don't talk enough about the fact that laminectomy alone can be helpful. I know it's out of vogue and people don't do it as much, but let me tell you that in some of my older patients who's already ankylosed and there's no motion, if they only have 1 or 2 level of decompress, all they need, that's a great operation. Kyphotic angle less than 10 degrees, you can treat as normal spine. Severe kyphosis, reducible, no problem, laminectomy infusion. If it's not reducible with less than 2 levels, you can get away with ACDF to correct that. Greater than, corpectomy. If there's space, subperitoneal space available, then you may only need to do a posterior fusion to augment it. If not, you would have to do posterior decompression as well. So what about my patient that I showed you earlier? Well, you know, I like to rely on my friends from time to time to figure out these difficult complication patients. So I decided to call up my colleagues in Cleveland Clinic, University of Wisconsin, and they were all quite different as to what they would do. And it totally got me confused. I'm going, well, I'm going to call somebody who really knows his stuff. So I figured I would call Dr. Abolfotouh and send a patient on a one-way ticket to Dubai to take care of him. So ultimately speaking, I just want to tell you, you know, it's not how you get there, but how you get there with style that matters. All the techniques we talked about are great, just to find the right patient to do it. Thank you very much.
Thank you, Don, for an excellent presentation. Always funny. We'll be waiting for that patient, by the way, Don.
Okay.
Makes it to Dubai. All right, guys. So you have heard the several surgical options that we have for cervical degenerative disc disease. It's time for your questions and answers. For the question and answer session, you can type your question down in the box, in the chat box. Just make sure when you do that, you post your question for everyone so that everyone can see your questions. The other option is to raise your hand and unmute yourself and go ahead and ask your question. Before we start,
okay, Sameh, yeah, sorry. We will start with the question of first lecture, okay?
Yes, exactly.
Yeah. Dr. Muzahim, I have many questions and I'm trying to summarize it. The first question that's they're asking you, why stand-alone cage?
Yes, this is a debatable issue, Ghazwan. There is a lot of papers published in this regard. Why stand-alone? Why not plate? And I summarized in the talk that actually why a plate? The answer is why a plate? More cost, more time, possible dysphagia. So why a plate? I personally use the plate since the last five, 6, 7 years. I use plate when I used for 2 levels, but nowadays I stopped using plates. I found no much additive effect on a plate, only cost and more time and more possible dysphagia. And I've reviewed many papers in this regard. Although plates, there is papers postulated that plates increase the fusion rate. There is an additive benefit, but we have to make a balance between the benefit and the complication and the risk.
Yeah, the second question come in this talk. What about the using?
I didn't get the question. I didn't hear it, please.
Yeah, what about the, as we all know that cage alone on long-term follow-up, there is more risk of cage subsidence. What's your opinion in that matter?
Again, cage subsidence is something is not related to only the procedure itself. It related to the details of the procedure. If you prepare the end plates very good, if you use the proper cage, if you use proper size, the risk of subsidence is much less. And if you used an undersized cage, not prepare the end plates, not use the proper cage, yes, there is a risk of subsidence. But as any kind of surgery, the risk of subsidence, I think it's reported in the literatures. It's between 3 to 5%, not more than this, if you are do it in the proper way. And the subsidence is more with the titanium cage, but it is the fusion rates again more also with titanium cage. So there is the selection of the cage is also play part in this regard. If you use titanium, if you use a peak cage,
so
yeah.
Yeah, in your cases, when you are using a standalone cage, especially in 2 or 3 level, for how long you are keeping your patient with the collar, and what type of collar you are using?
Personally, I don't like to use collar in these cases, but I use it for a short period, like 2 to 4 weeks, just as a protection method, because it will not affect the result if you are using if you do a proper surgery, but it will just the patient will feel that he has to eliminate some excessive movement. Otherwise, I don't like to use the collar in post-operative period for a long time.
I think you are brave in this point, because lots of paper talking about using collar for at least 8 weeks or more. So another question about the risk of C5 traction, nerve root traction in when you are doing a shoulder traction. Did you face any?
It's reported in the literature. Fortunately, I don't have cases like this. If you do it in the delicate manner, you will not face a problem like this. C5 nerve root palsy, as mentioned in the literature, is more common with the posterior approach, and with this maneuvers, I never experienced a case like this.
So another question about your approach. You are going left or right, depends on the pathology, right? If you are
Right.
pathology in the left, you are going to the right. So you are not going, let's say, on a single side, because personally I'm doing on the left side, while the other, as you mentioned in your literature, in your talk, many literature is debatable, and I think the most strong reference is that it's a surgeon preference, right?
Yes, in my cases, I depend on the pathology. I don't follow that rule, that left or right, recurrent hernia for other issues. I try to tackle the pathology, and I do delicate soft tissue handling. So I never experienced. Thanks for that, a single case of.
Yeah. Thank you, Mzaham. Last question, I think we can answer all about using dynamic MRI. I think we need special equipment, not machine. There are 2 types of dynamic MRI. Either we are doing it by using dynamic MRI machine, or we can use a supported pillow that's doing a flexion extension on 2 sessions of MRI to overcome the static. So this is the point, right?
Yes. Preoperatively, to see whether a hyperextension position will increase the patient's symptoms. Because if I have a case like this, especially in myelopathy, I'll try not to do hyperextension position during the operations to avoid the consequences of this approach.
Okay, thank you. Sameh, you will take for Naif question.
Yes, Naif, there is a question for you from Dr. Saad Hamdan. I don't know if you guys can see the questions, but do you always measure the sagittal balance in posterior cervical fixation?
Not really. Maybe some experienced surgeon, Dr. Moore or Oscar, can tell us more. But I would say, to me, the only time I do it if I'm suspicious about sagittal imbalance clinically, or if the T1 slope is very slow, like very low, like almost like 0. Just to give me some hint about the harmony of the other curves. Like the other case I presented, if you go too crazy about the lordosis, then you will alter the harmony of the other curves too.
All right, and there was another question asking, so you presented the case in which the patient is very stiff in a straight position, he doesn't have any cervical lordosis, and then there was a question that if you fuse this patient in straight position and he needs a future lumbar thoracic surgery, that's something that you put into account when you fuse those patients?
So again, that patient, all of his curves are not within the normal ranges we used to have or to see in clinical setting. His curves are reduced. He's hypolordotic in the cervical spine, hypokyphotic in the thoracic, and hypolordotic in the lumbar. So I would say I'm not gonna go crazy about him. It's more like specific, like patient-specific measurements. So I'm not gonna change what he's sitting at.
All right. Have you ever experienced any reperfusion injuries? What are your thoughts on those?
Again, sorry?
Reperfusion injuries from posterior decompression?
Not yet, hopefully not, but I haven't had enough experiences to say yes. I don't want to do that too, but.
What about you, Don?
Yeah, unfortunately that we had one patient last year who had chronic cervical kyphosis, circumferential stenosis, and ongoing myelopathy with signal change, who happened to have central cord syndrome on top of all this after a fall. And based on the overall alignment issue, we felt that, okay, we need to take care of him from anterior and posterior. There's no way we can get that cord to be compressed because it was completely compressed circumferentially. And we, unfortunately, he got worse post-operatively. And we always talk about in these chronically compressed patients that there's a chance you could have ascending progression of the disease, even whether it's traumatic or not. But I find that it's more common with post-trauma patients. And I think this unfortunate gentleman had predisposed hypovascularity to the cord already. And when you decompress them circumferentially, there's a much more rapid flow of vasculature into those areas. And that's at least the hypothesis causes that reperfusion or white cord syndrome kind of condition. And you just never know. And it's one of those things that we have to warn that patient about. You know, we do have to take care of the patient where the problem is. Fortunately, like I said, he had circumferential stenosis. And it's a real devastating problem, but I don't know if there's any way to avoid it. I just have to be aware of it and inform the patient the possibility.
Yeah, I think the literature is really weak when we're talking about reperfusion injury or white cord syndrome, as they call it.
Right.
All the best level of literature that we have is at level 3 at max, right? Or a couple of years like level 4 or something, but we don't really have solid literature that can tell us predictors of reperfusion injury in such patients. Oscar, I actually have one question for you. So in countries like the United States and actually here in Dubai, since we follow the FDA regulations, you know, in America, it's we can only do 2 levels of surgery, and that's actually not for all the implants in the market. That's for 3 of the companies right now that are running disc replacements in the market. So if we can do that, would you be a fan of the hybrid technique in case you have a 3-level disc herniation?
I didn't show cases with are you hear me?
Yes.
Yeah, sorry.
Yes.
So I didn't show cases with hybrid situations because I was supposed to defend the arthroplasty, but that's certainly things that we do. You know, I think it's a great operation, hybrid construct. In a way, you get the best of both worlds, right? So you can apply TDR in more mobile and fusion in more spondylotic levels. Okay, there is no really good studies, either clinical or in vivo studies showing that you should do arthroplasty above or below fusion. It really is, from a biomechanical point of view, is really the same. So I tend to offer fusion in the hybrid context to more spondylotic levels, or let's say if you're doing a 5, 6, 6, 7, do fusion in 6, 7 where you expect less motion. So that would be my rules.
Can I have a question?
Sure.
Oscar, I have 2 questions for you, please. What's your experience with the heterotopic ossification on cases with the TDR, especially multi-level cases, and what's its clinical impact on the result on your surgery? And the question 2 is about the C3-4 levels. We all know that C3-4 is very small disc with very less motion. Would you prefer to do a TDR in cases where there's pathology in this level?
Okay, so regarding heterotopic calcification, in this paper that we published just a month ago, the incidence of heterotopic calcification was 7%, and I think it's not HO. It's not related with arthroplasty. You can have HO with fusion as well. We have patients like that after years you see again calcification behind the disc level. But certainly there are a lot of technical issues to reduce heterotopic calcification. Of course, irrigation, abundant irrigation of before implanting the prosthesis is number one. Very important also to remove OPLL, posterior ligament, PLL all the time. PLL acts as a scaffold for ossification. Okay. Then I try to bone wax all the bone, cancellous bone surfaces that you have exposed it at the end of the surgery. And of course, be careful with drilling, not over drilling the end plates. And I think it's very important also to get the biggest prosthesis that you can have. Get a very good end plate coverage with your prosthesis. So always try to fit the biggest one that you can in terms of covering the end plate. And this, for me, are the things that you have in your hands to reduce the heterotopic calcification. And once you have the heterotopic calcification, it has to be very severe to have an impact, a clinical impact. And what you see most of the time is, although there is some degree of calcification, grade 1, grade 2, prosthesis is still mobile. So there is still a biomechanical beneficial from that. Okay. And your second question.
Thank you, Oscar. Yeah. We have two papers of a question about Oscar talks as usual. First of all, are you routinely remove the PLL in your cases?
Yes. So that was the reason. PLL is negligible in terms of stability, even if you remove it. You increase very few grades or not even grades if you remove it. And why it's important to remove it? To avoid this scaffold for heterotopic calcification, and to be able to inspect for disc material behind the ligament, or if you have osteophytes, I don't see how you can remove them unless you go behind the ligament, okay? Because you have to pass your Carrison under the ligament to be able to remove the osteophytes. So these are the three reasons I removed the PLL.
All right, we have a question. I see a few people here raising their hands. I can see Dr. Mohammed Al-Mishtawi. You can go ahead, unmute yourself and ask your question. Dr. Mishtawi?
Yes, Hussam. Assalamu alaikum. Thanks both organizing committee and the respectable panel for this comprehensive booster dose of degenerative cervical spine surgical options. Actually, I have two questions. The first goes to Muzahim and Oscar, and the second to Naif. The first question for Muzahim and Oscar. Before all, I enjoyed your calm, honest, defending debate. Actually, I would like to know your opinion about DCI, dynamic cervical implant. The solution is standing between ECDF and TDR. I mean, it limits motion to a level, and it also allows the stability by stiffness to a level. Hopefully, I like to hear your experience, and I'm pretty sure that you have with DCI. The second question to Naif. First, thanks for a nice presentation. About cord shift phenomena, you mentioned as a definite reason behind the C5-6 radiculopathy, the cord shift phenomena. Actually, I don't agree with that. In 2005, we published an article in Neurosurgery Review Journal about this issue, studying more than 1,000 cases of different neurodecompressive anterior, posterior, combined cervical approaches, single, multiple levels. Honestly, we want at that time to figure out what's called cord shift phenomena. We didn't find a direct relationship between C5 or C6 motor weaknesses and the cord shift seen in MRI in even one single case. Of 15 out of 11 cases had this noisy confounding postoperative complication. I think the main cause behind it is direct traction applied with abuse pre-operatively or undue traction intraoperatively. More recently, CSF dynamics alteration may be a possible cause. Thank you.
Thank you.
Okay, regarding the first question, the DCI, I guess, I never had the courage to use it. I think it's one of those, I don't know if done as a kind of car to typify this implant, but it's neither fusion, it's neither motion. Post-operative alignment is probably not as good as we should have. So honestly, I don't have experience. I never had the courage to use it. So I can't really say more than what I read from the literature.
Okay, hello again. Are you hearing me?
Yeah.
Yeah, about one of the pitfalls of the TDR, as they mentioned, that's about the learning curve. So you have to be precise in the location of the disc and also the size of the disc, right?
Right.
Yeah.
I mean, as the first speaker showed, the technique is really the same. The approach is the same. The only thing is you have to have a constant notion where midline is. Okay. You have to be very, in order for the prosthesis to work, to function properly, you have to really be very careful in sagittal and coronal positioning of the prosthesis.
Yeah.
And probably you have to do a little bit more also of uncus resection to allow motion of the prosthesis. And whereas in ACDF you do uncus resection more tailored to the compression, in TDR you probably have to do a little bit more release of the uncus to have a good motion of the prosthesis.
What are you using TDR in the young traumatic patient with disc pathology and intact facet pathology?
Yes, I mean I showed that case because I think it was interesting. Of course, major instability was excluded. Posterior elements were intact. So this was kind of really a traumatic disc herniation, but with a big hypermobility, with, as I showed you, 17 degrees or something like that. And my question was thinking the opposite way. We are used to think as a TDR as a way of preserving mobility. My question, or what I learned from that case is, can TDR also limit hypermobility? And that was the case. I was happy to see that by inserting the TDR, we were able to control the excessive motion of the index level. So I learned something from that case. But you have to carefully look at case by case before you apply this technique on a large scale.
Yeah, you mentioned in your talk about using the TDR in over collapsed disc, right?
Yes.
So what about the condition of the facet in this patient? As we know, over collapsed disc lead to facet arthritis. So,
of course, I mean this is something that you have to assess in MRI or CT if you have, is the condition of facet joints. Also, preoperative X-ray, dynamic X-ray can give you a clue. I mean, if the disc is collapsed and there is no segmental motion on dynamic X-rays, there is no indication at all to use a TDR.
Yeah. About the cost that you mentioned, that TDR is cheaper than ACDF. You mean the surgery itself or the whole healthcare let's say service that's taken over?
Yes, I mean, if you look at it in a longer perspective, there are a lot of studies now coming out showing that TDR is cheaper than ACDF. The thing is, I live in a country where my options in terms of anterior approach at the disc level is ACDF with a kind of 0P cage with incorporated screws, okay? I stopped to do standalone some time ago. We can discuss why, but that's I do a lot of kind of 0P with incorporated screws. And if you put the price of a 0P cage, for example, or similar, with a cervical disc prosthesis, in my country is really the same price. So I don't have this economical bias in terms of the cost of the surgery. So I am more free to choose whatever I want to do.
So did you face any case of disc misplacement, especially in multiple level cases?
I mean, it can happen that you don't have a perfectly positioned prosthesis. This can happen, but migration, mobilization, I never saw that. I had only one case that I had to revise due to infection. You know, I can't remember need for revision surgery at index level with cervical disc prosthesis. Yeah. And also, I can remember probably one case of adjacent level reoperation with TDR. And I follow my patients, and I got reviews from ACDFs. The patients come for review surgery at adjacent level disease, but they don't come with arthroplasty. And I do arthroplasty for a long time. So we have not studied that with numbers, but that's my clear impression.
Last question. What about the post-operative pain in patient with TDR who already has degenerative disc disease?
You mean neck pain?
Yeah, neck pain.
I mean, neck pain can come if you overstretch the disc space and you have some pressures on the facet joints, or you have already some facet joint pain preoperatively, but it's not related to the disc prosthesis compared with fusion, at least in the early postoperative period. The stability, the primary stability is very good. I mean, it's not an issue.
Thank you, Oscar. Now, last talk, Sameh, you will take the question.
Don, Don has an OR actually in 5 minutes. He's already late for his OR, so we'll have to excuse Don to go back to his OR. So Don, thank you very much for being with us.
I could probably handle one or two questions before I go. Yeah, if there's any.
If anyone has questions to Don before he leaves.
Actually, Sameh, I gave you 2 questions and no one of them is answered. The first one, I have a half answer by Oscar, and the first question need an answer from Muzahib, and already have a second question to Naif. And Dr. Ghazwan, yes, take my time, I thought.
Hello, Muhammad, how are you?
How are you, Muzahib?
Okay, fine. Miss you, brother.
I'm fine. Very nice presentations.
Yeah, thank you so much, Muhammad. Muhammad, the answer of the first question, that actually, personally, I don't have an experience with this kind of device, but I have a chance to read literatures on this device. I have found that it's just like in lumbar devices when you use the same principles. The results are not promising. Need more RCT studies. It's a halfway between it will not get, you will not get all the benefits of TDR, and you will not get all the benefits of ACDF, but in the midway you will get the complications from both. So I think from theoretical point of view, it's not an ideal solution, but we need again more studies to prove that. And again, from my experience, I don't have an experience. I never used this device.
Thank you, Muzah.
For me, talking about this. Sorry.
For your answer, sorry, Don. I don't want you to be late for your OR because we'll keep having.
Thank you, Don, for your attendance.
Oh, thank you. All right, goodbye, guys.
Don, thank you. Bye. Right, Naif, go ahead and.
So, thank you very much, Dr. Mohammed, for your question. So, your theory has some sense to me, and based on my other readings, there is always some theories about the reason of C5 palsy, and I'm humbled in the presence of other professors like you and other Dr. Hussam Salah and others I could only correlate to whatever written in the literature, but I cannot explain that from my own practice.
Thanks, Dr. Naif.
All right, we have a couple of raised hands over here. Before I forgot, I wanted to ask Professor Maziad to ask his question. I promised him to be able to ask his question by the end of the webinar. So if you're still around, please go and ask your question. All right.
So, yes, I am Dr. Maziad. I am around. Yes. Hello?
Go ahead, Dr. Maziad.
Yes, what is the answer? And I write another question so you can answer them together. You read my question, which I have written.
All right, can you ask your question out loud so that everyone can hear it?
Yes, my question for the arthroplasty, if you select the case which have 4-level osteophytes, 4-level osteophyte, at each disc anterior there is big osteophyte. This means there is a stiffness of the disc and the height of the disc is reduced. This is extended or extensive degenerative cascade going on the cervical spine. If we select this particular patient for multi-level disc replacement, I ask, what about the end result? Is it the global motion and every level motion? So what, and after 2 years, is this osteophyte returning back again? And it ended up with extended fusion, more expensive fusion, as we know. That is a question to be answered by professor who gives the arthroplasty talk.
All right, that's a question for you, Oscar.
So it's really a good question. I mean, the case you are exposing is probably end of the line case. I mean, when you have myelopathy or progressive myelopathy with disease at disc level, you have different stages of the disease in different disc levels, okay? It's very hard, the situation that you are describing, that you have all 4 levels with big osteophytes. I mean, certainly, if this is the case, I would not do an arthroplasty. It's completely a nonsense operation. Having said that, there is always a disc that it's less spondylotic, less osteophytic, so you can do in a scenario like you are drawing an hybrid construct. So my multi-levels are more for younger patients with multi-level disease. Most of them still soft disc disease. You can have one or another disc a little bit more osteophytic, but I would never do a 4-level arthroplasty for a case that you are describing.
Right, I have Professor Hussam Salah. If you can go ahead and mute yourself and ask your question.
Well, good afternoon, everyone. Thank you, Sameh. Thank you, Ms. Wen, and the rest of the distinguished faculty who have presented us very interesting presentations. My quick question to Oscar is, there is an element, a dynamic element to cervical spondylotic myelopathy that we see often in patients. Now, in these patients, would you suggest a TDR for them? And if not, or if so, how do you identify this? Is there a certain limit that you would say, well, this is not enough, this needs to be stabilized, or would the TDR be suitable for it?
Hi, Hussam.
Yes, hi.
Hi, good to have you here on and we have a very hello.
Yes, I can hear you. Yes.
There are other people on the line. So Hussam, you know, this is really a good question. There is only one paper addressing the issue of canal diameter and TDR on congenital stenosis patients. Okay, so TDR is only a good solution if you have pathology at the disc level. And even so, if you have a section around area of the cord less than 6 millimeters, TDR, it's really not an indication. And whenever you have excessive motion linked with compression, this is an overkill for progression of myelopathy. So in those cases, you really have to decompress and fuse. That's the key issue. And this has been shown very nice by Matsunaga paper that showed that the patients which were more mobile were the ones who the stenosis play a bigger role on the progression of myelopathy. So pay attention to the section, the area of the cord, and this is too tight. And on top of that, a lot of motion. This is something that you should decompress and fuse.
All right, we're running out of time, guys. So we'll be taking the last question from Professor Muhammad Khattab. Then we'll be jumping to our case resolution.
Thank you, Sameh. Thank you for the whole faculty for the nice presentation. I'd like to comment regarding Oscar Alves' presentation. Actually, I can find some extreme indications like using total disc replacement in DISH. You cannot apply total disc replacement for DISH patient. And also in collapsed disc, as Professor Mazid comment, in severe collapsed disc, the posterior facets as well are affected. So restoring the motion can increase the pain from the collapsed arthritic posterior facets as well. And also you indicated it for some trauma cases as to decrease the motion, the instability, the hypermobility, which is completely, I think we cannot launch that as an indication. I think trauma is a contraindication for total disc replacement as well. You need to fix, you need to stabilize, not to reduce the motion. You cannot guarantee the motion after total disc replacement. So I only disagree with application of these procedures in DISH, in severe collapsed multi-level cases, in trauma cases, and as well, some reports in the literature indicate that the autofusion is up to 30 to 40%. I know that there are some techniques to decrease the incidence of these heterotrophic ossification, but it is in the literature up to 40%. So be careful with your indications regarding total disc replacement, because some of the juniors are here and they can apply this for this patient, which is completely unaccepted in most of the communities. Also, there is a comment regarding Don presentation. There are some reported literature that there is progression in the OPLL, ossification of the posterior longitudinal ligament after doing laminoplasty. So the current recommendation is to do fusion and fixation for patients with myelopathy due to OPLL, not only laminoplasty because of the progression of the disease. Thank you for everyone. Nice presentations, but these are very important comments that I'd like to share with you. Thank you, Sameh.
Thank you, Khattab, for your comments. I agree with you regarding the ADRs. I think it's a great technology. We use it all.
You know, can I just make a point here?
Sure, go ahead.
Yeah, of course. I mean, I fully agree with what you said. I mean, it's and thank you for clarifying that. I mean, this case, as we have this big experience with TDR, we sometimes want to push a little bit the limits of the indications. And the clinical result in this case speaks for itself. We have this patient for more than 4 years follow-up. The prosthesis is mobile, patient is symptom-free, and amazing, you didn't see any regrowth of the anterior ligament calcification. As for the trauma case, I fully agree with you. There is no point in doing arthroplasty in trauma patients. This was really a very selected case that we dared to do the operation. We had a very good result. And we were, in a way, happy to see that the disc prosthesis itself offers some limitation to hypermobility. This was just to challenge the concept, nothing else. During my presentation, I said that this cannot be applied in large scale. I was very clear on that, but thank you again for stressing that.
Thank you, Oscar, and thank you all, guys, for all your questions. Unfortunately, we wouldn't be able to take more questions at this point because of the time issue. So we'll jump quickly to the case resolution. So as a just to remember, that was a 38 years old female patient who had an element of radiculopathy with myelopathy. Those were her x-rays, and that was her MRI. And we elected to go with a 3-level ACDF for that patient. Ghazwan, you want to go with your special case really quick?
I can comment on that.
Sure.
I mean, you're talking about the 30-year-old male. I mean, this guy can live another 50 years. Certainly, you will see some problems from this fusion at 3 level. And I think the motion limitation has a major impact on the quality of life of this patient. And that's what I tried to say in my presentation. For these young patients with multiple level disease, I mean, you should be very careful in offering fusion. As I showed on that very nice biomechanical study by Pat Worden, as far as you get older, there is a tendency to increase your SVA. There are compensatory mechanisms that allow you to have horizontal gaze. And by fusing 3 levels, you are abolishing completely this compensatory mechanism. So that's something that we have to be very careful in young patients. So why not to start with a TDR? Okay, if down the road, 10 years, 15 years, 20 years, it gets fused, that's okay. I mean, it's not a problem, but there was a benefit from while it was moving. And so I honestly, I don't do any more of this 3-level fusion in such a young patients. And my results speaks from themselves, and we have published that, and that's our understanding.
Sameh, do you have the axial cut?
You mean for the MRI?
Yeah. I've seen the, I mean, if it is my case, I will not go to the extremes. I will not go do 3-level fusion rather than 3-level TDR. I will tackle C5, 6 as I think it's the main pathology there. And then maybe, because as Oscar mentioned, she is a 38 years old. I mean, it seems to be like there is a one level that causes most of the symptoms, and maybe the rest will be partly responsible for the symptoms. And the decision to go for 3-level ACDF or 3-level TDR in 38 years old age, I think it's goes to more or less to an extreme kind of treatment. This is my just.
No, I agree with you. I mean, it's questionable here in this case if you have to do the 3-level surgery. I would probably do just 1 level, the most symptomatic, and do a TDR.
All right, Ghazwan. Yeah.
Hello?
Yes.
Okay, again, yeah. This is, we will end up with this case, which is interesting case, actually. 38, again, years old male. He's orthopedic spine surgeon, 4 week of radiculopathy and weak triceps. Next, Sameh, this is the picture that's give the decision for this surgery. Actually, this is the MRI of mine, actually. Next, Sameh. Yeah, this is it was in 2017. I suffered from right radiculopathy, and actually I didn't get the CT as the disc was calcified. I was confused looking for an option, whether ACDF or TDR, and I consult Professor Oscar at that time. I was in Istanbul. Then we traveled to Porto, and I did the surgery at that time. Next, Sameh. Yeah, this is my journey within August 17. I reached the hospital on Friday, on Wednesday before, yeah, and I did surgery on Thursday. This is the second picture, my first day in the beach of Porto, and day 4 I was back to my home through long flight, about 5 to 7 hours. Then on day 10, which is I didn't tell my doctor that I'm forced to do surgery. on day 10, which is a complicated spine surgery, cervico-dorsal fusion on day 10 with assistant of my resident actually. And last picture, this is the X-ray on 33 months post-op. I did the X-ray yesterday actually, which is AP lateral flexion extension. So I'm happy with the result, and thank you, Oscar, for your great job actually. And I'm totally biased toward TDR.
Okay, thank you. This was a good surprise. Yeah. Thank you for showing your own case.
Thank you.
It was my pleasure. Thank you.
Yeah. Right. Yeah. Just to recap, thank you guys. Thank you everyone. Thank you to all the attendees. Thank you as well for the cooperation for this webinar. Thanks you.
Yeah. Thank you, Sameh. You did a great job actually.
Excellent speakers, Muzahem, Oscar, Naif, and Damour, who left already. Thank you guys. Wonderful presentations, and always great having you on board. Just before we go, those are reminders of the coming webinars that we have. And a last reminder of the AO Spine Fellowships. The application started on May 1st, and the deadline for the application is May 31st. So guys, don't hesitate and apply for AO Spine Fellowships. You may be one of those lucky ones who can get an opportunity to join a wonderful training in one of the well-known institutions worldwide. Last but not least, thanks everyone for being here today, and hopefully we can see you in our upcoming events. Stay safe and enjoy the rest of your day.
Thank you, Sameh.
Thank you.
Thank you.